speaker is Dr. Marco Scipioni. Marco is a clinical pharmacist. As you can see on the slide, he's a clinical pharmacy specialist in infectious disease. He's the residency program director for the PG Year 2 Infectious Diseases Residency Program at the Detroit Medical Center. He's also adjunct faculty at the Eugene Applebaum College of... Could I have the slide back, please? Okay, it shows Sanjay Ravankar on the screen. Could I have, okay, very good. Thank you. Dr. Scipioni is board certified in pharmacotherapy with added qualifications in infectious diseases. His research interests in antimicrobial resistance and stewardship. He's published several papers in various journals, presented over 30 abstracts at various national pharmacy and ID conference. The reason why I said this is revolutionary is he is a clinical pharmacist. You seldom see a clinical pharmacist giving a lecture in an infectious diseases conference anywhere in India. In the United States, we have a category of people called clinical pharmacists. They participate in the ward rounds in order to advise the infectious diseases team with good stewardship. Whether it's the antibiotic is appropriate, what should be the dose, what should be the duration, what would be the drug interactions with other drugs the patient might be receiving. Clinical pharmacists play an invaluable role in appropriate use of antimicrobials, particularly in the hospital setting. I would very much like to see something similar come up in the Indian hospitals as well. So to introduce this concept, I thought we will ask Dr. Marco Scipioni to talk about what he does in his daily life at work. So to make you aware that there is such a category of individuals making extremely valuable contribution in appropriate use of antimicrobials in hospitals. Marco, please take it away.
Thank you, Dr. Chandra. I hope everybody can hear me. I'm going to try and share my screen now. Hopefully this works. Let's see.
We can see it, but you have to put it in slide mode.
Okay, there you go. That looks better.
Not yet. Okay, yes, it's in the slideshow. Good.
Okay. All right, thank you very much. I appreciate the opportunity to talk today about the evolving role of clinical pharmacy as an integral part of antimicrobial stewardship. I want to just point out that I have no disclosures. And the objectives of my talk is to outline a brief history of antimicrobial stewardship within the United States, review the evolving role of clinical pharmacists within antimicrobial stewardship as we have come a long way, and then to discuss the potential future within antimicrobial stewardship. And so when antibiotics were introduced in the 1940s and 1950s with the sulfonamides and the penicillins, immediately we started to see antimicrobial resistance. And so with this, people started to discuss how do we prevent this resistance from occurring. And in the 1950s, it was identified that antibiotic overuse was linked with the hastening of this resistance. And this increased resistance was associated with increased mortality. In the 60s, it was, tried to prevent this from happening. And there were a lot of ID physicians out of the US trying to educate providers. And education was introduced as a method to persuade physicians to refrain from overprescribing antibiotics, which were life-saving drugs and are still life-saving drugs. But this really didn't have any effect on the actual overall use of antimicrobials in the United States and in Europe. And in the 70s, it was noted that the overall incidence of hospital infections did not actually decrease. The thought was that as more antibiotics were available, we're going to actually see decreased infections that patients need to get hospitalized for, but this didn't happen. And what they noticed in the 70s as well is that education was not having any impact on reducing the emergence of resistance. So in the 80s, there was a shift to a more kind of what we call activist role. They used kind of environmental activists as an example of how do we condemn the overuse of antibiotics. And they started to shift from just education to condemning the overuse of antibiotics and calling it wasteful and expensive. And there were infection control standards that were introduced to evaluate and conduct surveillance for these hospital infections. And in the 80s, the IDSA issued specific recommendations on how to adopt restriction policies for the use of select antimicrobials, but there was no strong recommendations that all hospitals need to implement these types of strategies. And in the 90s, we started to see hospitals adopting specific programs as opposed to just education to try to regulate antibiotic use in order to prevent the increasing resistance. And what we see in terms of using the term antimicrobial stewardship, it was the first article that used the term antimicrobial stewardship was published in the United States in 1996. And it highlighted that antimicrobials should be considered a non-renewable resource. Since that time, you can see by this graph, looking at the number of publications utilizing the term antimicrobial stewardship, since the early or mid 90s to the late to mid 2000s, you start to see an increase in the number of publications looking at antimicrobial stewardship. And over the last 10 years, and this is looking up to 2016, we can see that there are more and more publications looking at antimicrobial stewardship within the United States. One of the first studies that looked at antimicrobial stewardship and its impact on antibiotic use was a study published in 1997. And this was the first study that looked at the requirement for prior authorization for selected antimicrobials. And what the focus on for a lot of these early antimicrobial stewardship publications was on cost, because these antimicrobials were very expensive. In this study that looked at restricted policy for certain antibiotics, and the antibiotics are listed here that they had restricted, they looked at a similar time period in 1993 and 1994. And they found that when they restricted certain drugs such as amikacin, aztreonam, ceftazidime, ciprofloxacin, imipenem, and ticarcillin clavulanic acid, that they found that they reduced the antibiotic expenditure significantly from over $100,000 to $40,000. And what they found was that there was a slight increase in the use of non-restricted antibiotics, but this still didn't change the fact that they had an overall decrease in antimicrobial use in terms of cost. More importantly, what they found that with these restricted policies and prior authorization for selected antimicrobials, that there was no detrimental impact on survival. And so there was no poor clinical outcomes. And so they looked at all of those patients that had positive cultures before this prior authorization was implemented and after this stewardship program was implemented. And they found that the mortality, or the 30-day mortality, was the same. The 30-day survival was the same. It was 79% before the prior authorization and about 75% after. So there was no impact, necessarily detrimental impact, on kind of restricting these antimicrobials, which was always been the concern when you delay antimicrobial therapy or restrict certain therapies. And so this was the first study that showed that an antimicrobial stewardship can result in a shift from expensive broad spectrum antibiotics to more narrow spectrum agents. There was a cost savings involved. They did see some increased susceptibilities and lower rates of infections caused by drug-resistant bacteria. And this has been shown with other studies as well. And most importantly, the ASPs, or the antimicrobial stewardship programs, did not compromise patient care or result in suboptimal antibiotic use. So after that original study was published in 1997, the Society of Healthcare Epidemiology of America and the IDSA published a guideline for the prevention of antimicrobial resistance in hospitals. And what they recommended in this guideline was to establish a system for monitoring bacterial resistance, establish practice guidelines, adopt recommendations, and utilize hospital committees. But they didn't specify any specific interventions that should be made in order to prevent antimicrobial resistance. So it was more of a monitoring system and providing guidelines. Since that time, about 10 years later, the IDSA and SHEA published specific guidelines for developing institutional antimicrobial stewardship. And these guidelines differed from the previous ones from 10 years ago in that they actually set out specific interventions and reporting that should be done in order to improve antimicrobial use and decrease resistance. And so in terms of interventions, the recommendations that they set forth from these original guidelines were to create programs to convert patients from IV therapy to oral therapy, create prospective audit and feedback programs, or to have a restricted policy with approval. Other interventions, including dose optimization, education, and facility-specific guidelines were also recommended. And then they recommended reporting on antibiotic cost using metrics such as the defined daily dose and creating a way to monitor antibiotic use. But this monitoring and reporting was really geared towards cost avoidance and looking at justifying the use of these antimicrobial or the implementation of these antimicrobial stewardship programs to decrease cost, to justify its use to the higher ups within the healthcare system. And they were looking at process measures over outcome measures. Since that time, in 2016, a new updated guideline has been published from IDSA and SHEA. And this guideline is slightly different in that it's identifying which strategies have actually worked, which strategies can be implemented, and what kind of impact they can have. And along with the interventions and reporting that I mentioned on the previous slide, they also identified some other areas that can be improved upon or can be used to improve antimicrobial use. This includes kind of syndrome-based interventions, using prolonged infusions, dedicated pharmacokinetic services, rapid diagnostics, and an antibiotic timeout. And then the reporting, they shifted from looking at costs to more looking at outcomes, looking at duration of therapy, looking at administration data, mortality, risk of resistance, and readmissions. And so this has been sort of the shift from the early guidelines that were put out looking at just monitoring antimicrobial resistance to implementing and reviewing interventions that actually make a difference. So what role does the pharmacy department play in antimicrobial stewardship? So we have pharmacy directors, we have hospital pharmacists, and then we have antimicrobial stewardship pharmacists. And so I'll kind of at the end of this kind of identify which areas these pharmacist leaders and these pharmacists can have within antimicrobial stewardship within a hospital. And Dr. Chandra mentioned that we have clinical pharmacy services in the US, and specifically at the Detroit Medical Center, our clinical pharmacy program has been around since the 1980s. We had our postgraduate year one pharmacy residency, which is a general pharmacy residency after graduating from pharmacy school, was introduced in the mid 80s. And our specific infectious disease postgraduate year two residency program was implemented in the early to mid 90s as well. So our program has a lot of history and has a lot of involvement from the pharmacists, and this involvement has grown over the years since the early introduction of clinical pharmacists into the practice model at the hospital. So I want to focus on some specific interventions and areas where clinical pharmacy can have the biggest impact within antimicrobial stewardship. So these are the interventions that the guidelines from the IDSA recommend that we should implement. And so I want to focus on a few of them and talk about how our clinical pharmacy services can get involved and what kind of impact they can make. And so the ones I'm going to focus on are hospital pharmacy specific, such as IV to PO policies, dose optimization, dedicated pharmacy services for dosing medications, prolonged infusions, and then talk about where ID trained antimicrobial stewardship pharmacists can have an impact with core interventions such as prospective audit and feedback and restricted policies with approvals, as well as moving on towards rapid diagnostics as well. So kind of the four areas we'll talk about is IV to PO, the prospective audit, kind of core interventions, dose optimization, and rapid diagnostics. So regarding using IV to PO as one of your first strategies in terms of antimicrobial stewardship, the guidelines recommend to implement this to identify patients that can safely complete therapy with an oral regimen in order to reduce the need for IV catheters or outpatient IV antibiotic use. And it's been shown that this can increase the use of antibiotics, or the IV to PO program can increase the use of oral antibiotics and can reduce length of stay and cost. And this is something that can be integrated into routine pharmacy activities. So this is a slide that looks at different hospitals that have implemented IV to PO programs and what kind of impact they have. And so this strategy in terms of IV to PO conversion is what we call low-hanging fruit. It's something that can be initiated early on in an antimicrobial stewardship program, and it can involve hospital pharmacists. The program we have here at the Detroit Medical Center, we have an IV to PO policy. So any patient that is on certain antimicrobials that have high bioavailability, such as metronidazole, fluoroquinolones, azithromycin, can actually be converted from IV therapy to oral therapy if the patient meets certain criteria without any communication to the physician. And so the pharmacists have a lot of independence to review the patient's charts to identify which patients are tolerating other oral medications, are not having fevers, increased white count, are in the right situation where their gut is working so that they can get converted to PO therapy. And so a lot of studies have looked at, what kind of impact this has. And one of the studies that is listed here is something that was done at the Detroit Medical Center in 2005. And this was a prospective study that looked at pharmacy intervention to convert patients from IV to PO moxifloxacin. And what we found, or what they found at that time, was that drug acquisition costs savings were $110 per patient. And so this was significant if you have quite a few patients that are getting IV therapy. And this has been consistently shown with other studies that are listed here on the slide. Now, it's not always just about cost, and IV to PO programs definitely save money in terms of drug acquisition cost, but they also have impact on patient care and some other outcomes. So I have a couple other studies listed here. And one study looked at patients with community-acquired pneumonia that were getting an IV cephalosporin. And they had a randomized trial where certain patients were randomized to either continue the IV therapy for 7 days or to convert from IV cephalosporin to an oral cephalosporin by day 2. And what they found was that there was no difference in the actual duration of therapy overall. And there was no difference in how many patients had symptom improvement, but the length of stay decreased from 9, almost 10 days in patients that received IV therapy for the full course to 7 days for those that received oral therapy. And so they concluded that a decreased length of stay can be achieved even if the duration of therapy is similar with an IV to PO program. This other study listed here looked at an IV to PO program over 3 separate time periods, and they converted patients that were on IV antibiotics more than 24 hours. And so patients that were converted to oral antibiotics after 24 hours were less likely to have line complications. So they had less IV durations that decreased from 4 days to 3 days. And then they also were less likely to have line complications. So the patients switched to oral therapy had significantly less, or had less complications associated with the line. So this is another potential benefit of doing an IV to PO program utilizing hospital pharmacists that are using a standard criteria for converting patients over to oral therapy. Moving on to the kind of core strategies that antimicrobial stewardship is built off of, prospective audit or restricted formulary. And so I wanted to talk about this because these are the core components of any stewardship program as per the guidelines. And we know that both strategies, whether it be prospective audit, where patients are able to, or prescribers are able to give any antibiotic with review after 48 to 72 hours by a clinical pharmacist, or a restricted formulary where you can have to consult either an ID physician or ID pharmacist in order to continue a certain particular antibiotic. And so we know both of these strategies can significantly reduce antibiotic use, cost, and resistance. And so I'm not going to go through each of these individual studies, but I just wanted to point out that there are several studies looking at what kind of impact these interventions have. And so in these particular studies, most of them were looking at prospective audit and feedback and what kind of outcomes and what kind of benefits we would have in terms of antibiotic costs. And all of these studies showed a decrease in antibiotic expenditure from before the program was implemented to after the program was implemented. Now, again, cost is not the only thing that stewardship metrics should be based off of, and we've really been moving away from cost metrics to more of outcome metrics. And some of these studies have also identified that these interventions can impact length of stay. And so several of these studies identified a shorter length of stay when these prospective audit and feedback programs were implemented. And so I didn't want to talk necessarily about the role of clinical pharmacy in these particular strategies, because it's really well known that prospective audit and feedback or restricted policies can work. But I wanted to kind of talk about the role specifically of clinical pharmacists, because some programs are built on just having ID consults for antimicrobial approvals, or having ID fellows responsible for initiating or responsible for managing patients on certain antimicrobials. And so I wanted to just highlight this study that looked at the impact of a hospital-based antimicrobial program on clinical and economic outcomes. And what they did was they implemented an antimicrobial stewardship program, and they had a clinical pharmacist that was responsible for doing restricted antibiotic approvals, as well as prospectively evaluating these patients on specific medications. And they had pharmacists doing that certain times of the day and during certain days of the week. And then ID fellows were doing it during the weekends and other times of the day. And what they looked at was what was the impact or the comparison between the antimicrobial treatment managed by the stewardship program, or what they coined as the antimicrobial management team, versus the ID fellows. And so if you look at the number of patients that were treated and managed by the stewardship team versus the ID fellows, they found that there was a significant increase in the number of patients who were considered having appropriate antibiotic therapy when they were managed by the antimicrobial team. And they saw significant improvement in clinical cure and less failures when the clinical pharmacist was managing those antibiotic approvals and those prospective audit and feedbacks. Now, there may be several reasons why this occurs. If you come to Detroit and you kind of spend time with our ID fellows, you'll know that they're quite busy handling a lot of complex patients and a lot of complex cases. And so they may not have as much time dedicated to reviewing these individual patients to determine whether the therapy is appropriate or not. Where if you have a dedicated clinical pharmacist doing these reviews, doing these approvals, they can spend the time to actually ensure that therapy is appropriate and patients aren't getting extended courses of therapy. So they also looked at cost and what was the reason why these medications or these recommendations were not appropriate. And they found that the majority of the time, the ID fellows were allowing or keeping therapies that were too broad. And so, with the antimicrobial stewardship pharmacists, they were able to narrow therapy a little more than the ID fellows were willing to do in this particular case. And so it just sort of shows, the impact that a dedicated clinical pharmacist and stewardship team can have within a health system. The other kind of novel area that I wanted to talk about in terms of these core antimicrobial stewardship interventions is using pharmacy residents. And so this was a study that we had published when I was in New York. And this was looking at how can we get our PGY2 pharmacy residents involved. And so the previous study, I mentioned that the ID fellows were covering antimicrobial stewardship responsibilities on the weekends, and they may not have been able to spend as much time because of their regular clinical work. And so what we did was we utilized our PGY2 pharmacy residents in critical care and infectious diseases to expand our antimicrobial stewardship coverage into the weekends, and saw what kind of impact it had, and were they actually able to provide the same care and the same reviews that we did during the week. And so what we found was that the weekend coverage with the PGY2 pharmacy residents had even more interventions than we had during the weekday. And there could be several reasons for this. One of the reasons being that you have limited coverage on the weekdays, and so providers were more willing to reach out to the pharmacy residents on the weekends for support. And we didn't have clinical pharmacists rounding with the teams on the weekends, so there was more opportunities for interventions as opposed to the ID stewardship pharmacists. But it just shows that these graduates or these postgraduates that are not full clinical stewardship pharmacists can still have an impact even on the weekends. And so we also looked at, they did antibiotic approvals as well, and they had similar requests on the weekends as we did during the week, and they provided the same number of interventions in terms of the same number of approvals, making therapy changes, making dose recommendations. And so they had a similar impact on the weekends as a trainee that we did during the week. And so even if you don't have a fully trained ID clinical pharmacist, you can still have an impact within antimicrobial stewardship. So moving on to talk about other clinical roles that we can play as pharmacists. The guidelines recommend having pharmacokinetic monitoring programs for vanco and aminoglycosides, as they can reduce cost and decrease adverse events. And they also recommend to consider dosing strategies for beta-lactams, which is starting to become more prevalent over the last 10 years in order to improve outcomes and reduce costs. So how can pharmacists get involved? Or does this involvement with pharmacists actually have a big impact? So one of the first studies that looked at pharmacist management of pharmacokinetic dosing with vanco and aminoglycosides, they looked at patients that had management with a pharmacist for dosing of aminoglycosides and vanco, and those patients that did not. And they found that the overall cost when the patients were managed by a pharmacist was decreased. The overall drug cost was decreased, and even the laboratory cost was decreased in this particular study. But more importantly, they found when pharmacists managed vanco and aminoglycoside dosing in this particular study, that they showed that there was a shorter length of stay, almost a full day, or just over a full day, where these patients were able to get discharged faster. And they had less complications, such as hearing loss with aminoglycoside therapy, and then renal impairment with vanco and aminoglycosides. And so this shows that pharmacy management of dosing with vanco and aminoglycosides can have an impact on patients as well. And so they even showed in this study that there was a decrease in mortality in those patients with complications when they were managed by a pharmacist than those that weren't managed by a pharmacist. So it's not just cost, there are clinical implications for having pharmacists manage dosing of vanco and aminoglycosides. And I will say that at the Detroit Medical Center, we've been having clinical pharmacists dose and monitor vancomycin for quite a long time. And within the last 5 to 10 years, we've actually moved to an area under the curve or AUC dosing monitoring for vancomycin. And this is based on the new guidelines that came out from the ASHP IDSA and Society of Infectious Disease Pharmacists. And this therapeutic monitoring guideline is pushing to recommend AUC dosing. And the reason for AUC dosing is because, with a target AUC of 400 for Staph aureus, we can see increased improvement in clinical outcomes. And, when we used to do trough-based dosing, we used to see targets of 12 to 15 in order to try to get adequate concentrations of the drug. But what we found is that those trough concentrations may actually be more than what is necessary. So in this particular study that was one of the first studies looking at AUC dosing, they identified that with trough level dosing, the troughs were generally higher, which was leading to higher AUCs. Whereas when AUC dosing was implemented at the Detroit Medical Center, we found that our trough levels were on average lower, which meant that our AUC dosing was lower as well. And so, you know, in all fairness, does this actually make a difference when we're doing AUC dosing and using lower area under the curve or having lower concentrations that we're achieving? And it does make a difference. So it makes a big difference in terms of nephrotoxicity. And so this study also identified that when we moved over to AUC dosing, we saw a decrease in nephrotoxicity with Vanco. And so this is looking at patients that were monitored with trough monitoring versus those that were monitored with AUC. And so with AUC dosing, we're getting lower concentrations and we're getting less nephrotoxicity. And it's not just Vanco and aminoglycoside dosings where pharmacists can have an impact. It's also creating alternative dosing strategies for other medications such as beta-lactams. So we do prolonged infusions of all beta-lactams here at the DMC. Cefepime is infused over 3 hours, meropenem and Piptazo are all infused over 3 hours. And this study, which was published in 2011, looked at, this wasn't from DMC data, but this looks at the mortality for those patients that were getting extended infusion piperacillin tazobactam versus those that were not. And they saw in this particular study that there was a decrease in mortality in patients that were getting extended infusion piperacillin tazobactam versus other beta-lactams. So this strategy and this involvement in dosing actually still has an impact in mortality as well. So moving on to the last role that I wanted to talk about, or the last intervention with that stewardship pharmacists can get involved in, is rapid diagnostics. And so the guidelines from 2016 recommended to utilize rapid diagnostics in order to assist clinicians in interpreting and responding to results. And what they specifically mention is that this should be combined with active ASP support and interpretation. So this study looked at the role of rapid diagnostics for identifying Staph aureus, whether it was MSSA or MRSA. And this first figure looked at the number of patients that were switched to appropriate therapy for MSSA and MRSA when the rapid diagnostic PCR was introduced and before it was introduced. And they found that the number of patients that were switched to MSSA-directed therapy was higher in the post-rapid diagnostic group. They also looked at what was the mean time to antibiotic switch. And they found that the mean time to switch was significantly shorter in those patients that were had that rapid diagnostic, or after that rapid diagnostic tool was implemented. And so the IDSA guidelines recommend introducing these rapid diagnostics with the help of a stewardship or clinical pharmacist. And so what we see is that sometimes when we implement these rapid diagnostic programs, it does decrease the time to identification of these organisms. Like in this particular study, they decreased the time of identification for MRSA and MSSA from 2 days to 1 day. But it may not always increase or improve the time to optimal antibiotic therapy. And so in this particular study that showed an improved time to identification of MRSA, they actually didn't find, they didn't find a difference in the time to optimal antibiotic therapy. And so patients with MRSA or MSSA did not have an improved time to optimal antibiotic therapy. And the most likely reason for this is that they just implemented the rapid diagnostic without having anybody follow up on those results. And so clinicians may not have trusted the information or may not have been aware of that information, or have been aware that information was available. And so this study looked at what is the impact of having stewardship involvement in rapid diagnostic reporting. And so what they found was that when the rapid diagnostic was introduced, the time to appropriate de-escalation did not change. So it was 34 hours in the before group, 38 hours in the after group. And that time to appropriate de-escalation didn't change significantly until stewardship became involved. And so that time to appropriate de-escalation decreased to 21 hours in this particular study. So it kind of reiterates the impact that clinical pharmacists can have, or the stewardship program can have, when you implement these rapid diagnostic programs. So now kind of moving on to what role can each of these members of the pharmacy team have? So I think Dr. Ravankar had mentioned that you need to have buy-in for antifungal stewardship from the higher ups. And this is true for antimicrobial stewardship. So pharmacy directors can interact with hospital administrators, can commit to the antimicrobial stewardship program's mission by dedicating resources to the antimicrobial stewardship team. Hospital pharmacists that aren't necessarily trained in infectious diseases can have impacts on IV to PO switches and policies, dose optimization for vancomycin and aminoglycoside, therapeutic monitoring, and beta-lactam dose recommendations. And then antimicrobial stewardship trained pharmacists can have big impacts by participating in those core stewardship metrics, by planning and implementing these strategies. I didn't really talk about assessing the practices and analyzing the baseline data, collecting and reporting on how the stewardship program is having an impact, and then disseminating those findings. And then last, overcome pushback from other clinicians and other specialties that may not be interested in listening to the stewardship pharmacist's role. So the last slide I wanted to talk about was just the future of clinical pharmacy within ASP. I think we need to move more from a cost-based metric evaluation to look at clinical outcomes. We're lucky in the United States that the Medicare, Medicaid, and Joint Commission, which standardizes our hospital practices, require antimicrobial stewardship in all hospitals. So now we don't have to justify by cost. We can look at our clinical outcomes in terms of mortality, length of stay, recurrence and resistance. We're kind of need to go back to handshake antimicrobial stewardship, which is actually going back to the bedside, interacting with teams that are rounding on a regular basis, moving towards outpatient antibiotic therapy, looking at stewardship in the long-term care facilities, nursing home facilities, getting other disciplines involved, such as nurses. And then, as Dr. Ravankar mentioned, antifungal stewardship is becoming more important as well. And so with that, I'd be happy to answer any questions that you may have and talk about our program experience here at the Detroit Medical Center and how we get all of our pharmacists involved and how our clinical pharmacists are involved in stewardship.
Thanks, Marco. Thanks for the nice presentation. And I don't see any questions in the Q&A, but that's okay. I am going to pick on Kavita and Murali. You don't hear clinical pharmacists giving talks in infectious disease conferences in India. Clinical pharmacy is non-existent in India. So the idea of introducing Marco was to make the listeners here see the role clinical pharmacists could play in enhancing antimicrobial stewardship in the hospital setting and perhaps in the outpatient setting as well. This is a very new concept for India. So I hope the listeners, if there are administrators, begin to see what we have been doing here for over 40 years, as Marco pointed out. This is old stuff for us, and this needs implementation in India, particularly starting with large Indian medical schools that have pharmacy programs. Curriculum has to include clinical pharmacy, so we create the cadre of individuals that would function as clinical pharmacists, serving an extraordinarily important function in the hospitals. So let me open it up. Kavita, Murali, do you have any questions specific, not for me, but for Marco.
First of all, congratulations. It was a brilliant lecture by Marco, very impressive. To tell the status of pharmacy in our hospital, we have a very dynamic pharmacy practice department in our institution with the running PharmD program. So they have been doing research and they also have consideration to start people rounding with various departments, especially as team leaders and a group of few individuals working with the different departments to give inputs. I have had the privilege of working with PharmD people since about 20 years. We used to have some of the consultants who would come for rounds and they would suggest some dose adjustments in the rounds. However, there's a lot more to do in India, even with respect to all of this antimicrobial stewardship from pharmacy section. Also in our department, we have antimicrobial stewardship research going on with Muralidhar Verma is a principal investigator, and we have a research assistant who is a PharmD person who is helping him with that antimicrobial stewardship. Yes, so the beginning has been done, but there's a lot more things to be done.
Thank you. Thanks, Kavita. Murali, do you want to make any comments, Murali? Okay. So as I was mentioning, Marco Clinical Pharmacy it's in its infancy, as you just heard. And do you have any words of advice to this group? Marco?
Yeah, so before I give any words of advice, I do want to say, as I was, preparing this presentation, I was, doing some research on antimicrobial stewardship in India, and I have come across some papers and research to look at the impact that antimicrobial stewardship can have. So I think I agree. It is there. The one word of wisdom is it's a slow process. I think the biggest issue we had in the United States, and luckily this was before I had to come across this, was creating dedicated time for the pharmacist to spend on stewardship, instead of asking a pharmacist that needs to verify and make medications and do things within the pharmacy to provide dedicated time so that they can really focus on this important task. And the thing I kind of walked through very quickly was cost. Before these stewardship programs were implemented countrywide, we had to justify our positions by cost, and all stewardship programs will decrease antimicrobial use and cost and can be self-financing, if you will. And so once you cross that threshold and show that we can be, able to, we're not an increased burden and increased cost to the system, we're actually providing cost savings. And once you get over that hump, and then you can start to show the other clinical impact. It was probably the biggest issue and hurdle that had to be overcome within the United States. And luckily that happened before I, came along, and I've been able to benefit from, being a part of these stewardship programs that had that dedicated time. And so I think providing dedicated time, having the dedicated training will be a significant thing to have, and having champions to promote this is very important.
That's a very good point to note, that it should make economic sense for the hospitals to have this kind of clinical pharmacist, because at the end of the day, it's economics, so it has to make economic sense to have pharmacists advising on these things. Of course, when it comes to the cost of antimicrobials and the consequences, it will make sense. So it's a way to go. I agree.
But as Marco pointed out in his lecture over and over, it's just not the cost, it's the quality of care also substantially improves. That's an important point to note for us as clinicians.
I
Okay,
meant for
let's
the
go.
program directors to adopt or the administrators to adopt. They will also see from the economic point of view.
Absolutely
I definitely
right.
agree.
Okay, thank you, great. Thanks, Marco, thanks for your time.